Hi, everyone, and welcome to another edition of What's Up, Doc. And today we actually have Dr. Kevin Herman. He is an interventional radiologist at American Endovascular in New Jersey, Orange, New Jersey. I think that's where you're still out, but you have a few facilities around there that you're also on call at, or you have privileges at as well. So you're not only in your own office-based lab, but you also work out of, I think, multiple hospitals in that
Yeah.
area, as well as an interventional radiologist. I'm curious. I would love to get started with just explaining. So many people who have PAD, um, believe that only vascular surgeons can treat PAD. So I wanted to see if you wouldn't mind defining the role and education of an interventional radiologist and how you end up choosing PAD as a specialty.
Sure. First, thank you so much for having me on today. I know this wonderful organization, and it's a great service for both clinicians and for patients out there. And keep up the great work. And I'm just happy to be here to contribute. So I'm an interventional radiologist. I've been in practice for over 15 years. And the world of peripheral vascular disease is really changed a bit. As you mentioned, Kim, we have a office-based lab and ambulatory surgical center as part of American Endovascular in West Orange, New Jersey. We do have partners within the same facilities office in Manhattan, Queens, and Brooklyn as well. But we also have a very big peripheral vascular and critical limb ischemia program at the hospital, predominantly at Holy Name Hospital in Teaneck, where I think it's actually very important for patients, and I'm sure that you've had a lot of patients come through your message boards where they're both being seen in outpatient centers, but also a lot of patients do need some hospital care as well to manage other medical comorbidities, or there's also an acute aspect, emergent aspect to some of the disease processes. I mean, I like the name of CLI or CLTI, which could be critical, or I've always thought it as chronic limb ischemia as well. So that's why I feel like we're really geared very well to treat our patients both in a hospital and an outpatient setting. Going back to your question about interventional radiologists itself and the treatment of peripheral arterial disease. I think PAD, you can break it down really into a couple of different buckets if you want. There's peripheral vascular disease or peripheral arterial disease, which is really what we are talking about today are a disease process that's affecting the blood vessels that go down to your leg. There are other blood vessels that go to your neck, to your arms. Those are super important, and that's also part of the peripheral vascular space and world. But I think we're going to focus mostly on the blood vessels that go from your mid-abdomen and down to the legs that can really be affected by this disease process. So peripheral arterial disease can be there, and you may not even know you have it. It could be asymptomatic, and oftentimes that really is true. Patient has no idea that they have the disease. And that's one of the problems, kind of, because a lot of it is not just the interventional radiologist, the vascular specialist, the vascular surgeon treating the disease, but really the patient can be treating the process themselves, or sometimes making it worse, certainly by a lot of different lifestyle issues like smoking, for example, and poor dietary habit. Also, not taking medicine if they know that they have high cholesterol, or a patient suffers from diabetes, and they're not regularly, watching their diet, seeing a nutritionist, seeing the diabetologist, and making sure the sugars and the hemoglobin A1C are in check. So really the treatment starts with you in a sense, not just the physician, but trying to have that healthy lifestyle of eating and exercise. And sometimes the damage is already done and we can't prevent, that from getting worse. But we really do try to manage those risk factors initially in our treatment. Interventional radiology is a specialty that's been around for many, many years. It can be, as the three types of docs who intervene on vascular patients, I think maybe it is the least well known. Vascular surgery and interventional cardiology have a larger presence in general. They're larger fields. They're more fellows that graduate in those specialties. And oftentimes interventional radiologists have been sort of relegated to the performance of the procedure is more, if you will, they're the plumber, they come in and they kind of, can take care of the problem that let's say a cardiologist or a vascular surgeon had asked to be taken care of. But as the field developed and there's more interest in the medical aspect to it and managing risk factors for patients with peripheral vascular disease, we really became much more of a clinical specialty, if you will, and have the ability to see patients, to diagnose, to follow them up long term. So I think that the most important thing for patients to do is to really be seen, somebody who has vascular disease, be seen by someone who is passionate about it, because we all really overlap. If you create a Venn diagram, the middle overlap between all the specialties treating it can be a huge overlap, as long as you really passionate and recognize that you can try to do almost everything to try to help these patients.
Knowing what's actually possible in a minimally invasive way, being on the cutting edge, what would be your best advice for patients that, let's say, are on deck for amputation? Or I would even go back to the moment they get diagnosed and choose a doctor and they want to prevent that amputation. They don't want to have an amputation. They don't even want to get that far. We always say to the patient, it's important to choose the right doctor. So again, you knowing the real skill set that is necessary for way down the road when limb salvage may be possible, what are the skills that you would require if you were a patient of a doctor as you're choosing who's going to be your care team for the long term? What are those specific skill sets that you would require and questions you would ask to make sure that you can get those out of the doctor?
Right. So I may ask you to repeat part of that question in a minute, but what I want to first address is oftentimes timing is everything with these patients. And the reason why I say that is because you have a patient on a spectrum of peripheral arterial disease, like we were talking about in one bucket, who it's more of a chronic process that they are either asymptomatic or maybe they have what we call intermittent claudication, which is affecting their lifestyle overall, and they can't walk well. Those patients will present completely differently than a patient who has critical limb ischemia with a non-healing wound and ends up in an emergency room because they noticed the wound, they saw it for a couple of days, they sort of possibly ignored it, showed it maybe to another physician or their podiatrist, and I wouldn't want to say slow in getting care, but you see a little cut, and a lot of times it just goes away, and that's what you've been used to your whole life. But all of a sudden, because the blood vessels have been potentially damaged so many years, all of a sudden it's after hours, it's 6 o'clock on a Tuesday or on a weekend or on a holiday weekend, and you're like, wow, my foot is red, it's swollen, it's killing me. I got to go to the emergency room. In the emergency room, and one of the things that we're working on some of the societies that I'm on is trying to really get people who are on that front line that are going to see those patients to recognize what's the most important step. These are not necessarily emergencies yeah, you're going to have an amputation tomorrow. Otherwise, it's going to affect your whole body. You have to, take a step back. You want to make sure that the person, that the physician or other, practitioners taking a look at you, evaluating the entire picture, okay? Get the blood work, get the right laboratory evaluation, get the right ultrasound, not the wrong ultrasound. The reason why I say the wrong ultrasound, because oftentimes people are ordering the wrong Doppler type study, the wrong arterial imaging type study. They jump to something called a CTA or a CT angiogram or an MR angiogram or some nuclear study to see if there's active infection, and an MRI to see if there's, osteomyelitis. And they're jumping 10 steps ahead when really we know that there's one small blockage that maybe can be fixed or maybe can be watched. And we have to, make sure the patient, if there's an infection, gets on antibiotics. So you want somebody that takes really a whole approach up to the patient. And then once they're doing that, does the patient need to get admitted? If so, let's have somebody evaluate that patient from a vascular standpoint. From a vascular standpoint, you want that person, that physician, to have a lot of experience. you really need a lot of experience in dealing with these patients, not just because of the complexity of the procedure, because, sometimes we always had this saying. I used to work with an older vascular surgeon who's in long practice. It's like, well, let's just see if the wire goes. Yeah, because you can have those cases, and that means that you're in the procedure trying to restore blood flow. That can sometimes be easy. That could be the easiest part of the procedure, is just getting that wire to cross through the blockage. Sometimes it's the hardest part of the procedure. But the point being is that you need to know when you should go into that procedure. And if you don't have a lot of experience with patients with critical limb ischemia and advanced peripheral arterial disease, then that can be a problem. And when I talk about a lot of experience, I think somebody who's passionate about it and somebody who sees a lot of patients, has been doing this for 4 years or more, is usually potentially an expert in the field. Off hours, you may not get a physician like that, but as long as he's part of a team, or he or she is part of the team, that knows who to speak to and who to review, this very complicated process about. So that I
And
think
we
it's really
always,
key.
yeah, we always make sure that when you're talking to the vascular specialist, that you always, if they come in, even if you're in an emergency room, you want to make sure that, especially when you are dealing with someone who's a diabetic, someone who is CKD or ESRD, the advanced stage of chronic kidney disease, you want to make sure that you do have a below the knee expert, that you do have a doctor that is trained in, and when medically appropriate, is willing and has had proven outcomes, success in treating those below knee arteries and into the foot, the so-called the pedal loop, pedal plantar loop in the foot. And the doctors who aren't will tell you it can't be done, it shouldn't be done. But say that you want a pedal loop, right? Specialist, someone who does that all the time to at least review your case. You need that second opinion before they just jump in and say, well, we're just going to amputate. But there is a caveat to that. And I think Dr. Herman will agree with me. There is that line, and you were mentioning the bloods, and you're mentioning even the MRIs, but it's really those bloods. Um, if they're going to jump to amputation, your life is on the line. They know by the bloods that it's becoming systemic, that it's either your limb or your life.
Right. I think that that's very few and far between on initial presentations. And that's more of not in a patient who's had this chronic diabetes and comes in with this wound and the non-healing wound and gangrene. And it could be foul smelling gangrene that's coming on. You take off the dressing. That's not usually the type that needs that emergent amputation. Maybe if they get an X-ray and they show that there's some air in there, they think that there's an infection brewing. Yeah, that can sometimes jump to it. To me, the only times that I really feel that you're going to go to jump to that emergent amputation is when that leg, it's a dead leg. It is completely cold and there is no blood flow. Not that it's gangrenous and foul smelling. Sometimes that may be an emergency amputation, but I think that that's typically very rare. Also, one of the things in terms of the one of the things I always ask patients, because thank you for some referrals, and we're a tertiary or a quaternary center, I think, sometimes with our peripheral vascular patients
Yeah.
who have failed in other places. And to me, it's what was done. I'm always asking the patient, how many times was tried, and not only that, but also what entrance point did they go into the blood vessel? Did they go, if you're treating the left leg, did they go down that left leg? Did they try to go into your left foot? Did they try to go from the right side around, or maybe from the wrist? And I get clues from that to see, okay, this patient was seen by somebody who literally tried everything and tried all options. And then I know, okay, if we're going to be successful, we're going to work extra hard, and maybe we can really help out the patient. But sometimes you got a patient who doctor said there's nothing to do, we can't do anything, and I'm not criticizing, but we tried once from what we call the up and over approach. If you're trying to fix something all the way down in the foot, to try to do that from the all the way to the other side, it's just you run out of room. And so that sometimes gives me a sense of, okay, we really have a better shot at trying to be able to rectify some of this blood flow going down. So that level of expertise is important for me to gather from the patients to know what we're going to be able to manage their expectations and what we're going to get through.
Yeah, and I had mentioned as part of my really long-winded question that gave you two ends, and you answered the one end, which was the more extreme end, which is on deck for amputation, going straight in to an emergency room. To the opposite end is you were just diagnosed and you've been told you have peripheral artery disease. I really want patients to take choosing a doctor very seriously or choosing a team very seriously, and even having two different vascular doctors on their team to check in with, maybe one a vascular medicine doctor that is going to be, and it could be they could be combined, but someone that's going to manage them early on with the medications and making sure that they're in a walking program and doing with meeting with their diabetologist or endocrinologist or whomever it might be, etc., right? But then also that one that you need to make sure that you have someone for the long haul. What are the
Right.
skills? And you were mentioning some of them, and I'll tell you mine, and you can reiterate and expand or even feel free to say no. But I always say, and you hinted to it, is they got to be able to do the antegrade approach coming down from the top. And if that doesn't work, that they're willing to come up from the bottom for a retrograde approach to try and tackle that blockage as well. And they have to be willing and able, when medically appropriate, to open up those small vessels, not only in the calf, but in the foot.
Yeah. I think the other aspect that we always forget is, especially in the first set of patients who are not quite as advanced, is, do you really even need a procedure at all? And we always hear of these sort of horror stories, and I feel like they're getting less and less. That my doc told me that if I don't have this procedure done, we're gonna end up with an amputation. I'm like, maybe that's true, but let's see what's happening with your walking program. Go out and walk. Go out, walk. Oh, I
Yeah.
can't walk. It's too cold out. So go to the mall, walk around, take notes every time that you pass the Macy's or the Starbucks, and keep walking around. Oh, today we were able to, get from Starbucks to Macy's, and then let's say you get to the Starbucks a second time. So maybe treat yourself to something healthy, a healthy snack or something like that. And so those are the keys, in the very beginning, for you to really recognize who the type of physician that you want to be, taken care of, because it really is. It can be a lifelong sort of a marriage. And my
Mm-hmm.
favorite part is, we treat somebody who, and I have so many patients like this. And I've been in the same practice for 15 years. And I look back to some of the patients started seeing in, let's say 2009, 2010, something like that, where they had blockages. They were sent to me for a procedure. A CAT scan showed there was a blockage, and they occasionally have some knee pain. And we discussed it, and we said, you know what? Why don't we hold off? And now, 10 years later, finally, after walking, after managing lifestyle modifications, 10 years later, they're finally starting to exhaust those collaterals. And now we're getting set up, to potentially for either an endovascular procedure or possibly a surgical bypass, which would be performed by a different specialty. But you have to be able to recognize that. And only that experience shows you really that lifelong pursuit of the patient specifically with that disease. So I'm not sure if that answered your question. It was just something, anecdotally I wanted to bring about.
No, I think that that's an important point. It's interesting because has been a lot of media about these procedures too early, and it's interesting because with the Global PAD Association, I think I've had only one or two cases when a doctor went to intervene early. Most of the situations that I deal with
Right.
more than 12,000 patients around the world is doctors who won't treat or treat too late and only treat with open or um, bypass procedures or amputation. So it's very interesting, but I have had a few that have come to me and I'm like, are you serious? The doctor you're only 30 something years old. Or you need to,
Right.
have you even walked? Have you, exhausted all conservative medicine therapy? Have you, been on the statin, the blood thinner, cilostazol? I mean, all of these different things. There's so much out there. And I've
Did
only
you
had a
stop
couple of
smoking?
cases.
Like, oh, I
Oh,
forgot.
that's the other one.
Oh, yeah.
Oh, that's a good one because we still have people, and I understand, and we're not the type of people that actually go out there and lecture and you need to stop smoking. But I think it's important to know because we just had a patient that had 7 bypasses in a matter of 3 months and hadn't
Mm,
stopped smoking, and they couldn't figure out why he kept blocking, blocking, blocking. But 7 bypasses, veins taken out of everywhere. And meantime, they're redoing these bypasses and he keeps blocking, but he's still smoking.
yeah.
And no one had the conversation with him.
Yeah, and I always tell the patients, I said, listen, you smoke? Yeah, I smoke. That's so hard to stop smoking, doc. I get it. That's fine, and I'm not gonna necessarily lecture. I understand, we've been doing it, I have a lot of stresses in my life, and that's why we do it. It relieves it. I tell them I sometimes, somewhat jokingly, but tell them, listen, I'm a very competitive person myself. And I say, if you're not gonna stop smoking for yourself, at least stop smoking for me, because I don't want to see you back on this table, and then my numbers go down because I'm putting in a stent and it's closing down because you're starting to smoke. So at the very least, just so my numbers look better, please stop smoking. At least now for 6 months, we get, and then like, you know what? I went down from 10 to 2 to, and I say, see, the stent is open. See that? And, so if I see we're not getting anywhere with the regular smoking cessation, I try to, just do it for me, just because I want my numbers to look good, and.
I think that that's actually a really important point because I mean, doctors do get docked. I mean, they
Yeah.
think that this revolving door procedures is really fun for them and oh, it's big money making. No, no. These doctors are actually, they get docked, it weighs on their reputation. And also ultimately, right, reimbursement, from
Yeah.
Medicare because they're like, what are you not doing right? And so when it comes to nicotine, it makes the blood, would you mind going into it makes the blood sticky. And when you're going in and you're intervening in these vessels, it causes inflammation. And if you have sticky blood, where do you think the sticky blood's going to stick to those inflamed areas? And it's just going to block right back up.
Exactly. And there's a lot of damage that's already been done. And during the procedures also, we're actually part of the procedure, which is the angioplasty, which is the balloon expansion of the blood vessel. We're causing controlled damage to the blood vessel. So we're trying to actually somewhat damage that blood vessel so it could remodel and form better. And in that healing process, second take that one drag on the cigarette and it's going through you, it's just, I could just see my little stent or the balloon area that we treated just starting to get clogged.
Mhm.
I feel like if we saw it in real time, maybe, that would be great. I always wanted to try to get a stent that sort of shows you in real time, like it's starting to get blocked. And then it's like, wait a minute, you know what? Now that I see it, I gotta stop smoking, exercise a little bit more, and diet I think is super important, obviously, especially in diabetics. Um, but it's probably not as one-to-one of a ratio as with cigarettes specifically.
Definitely. And you mentioned walking. Walking is the best medicine. How do you walk effectively to grow those natural bypasses that can reroute blood flow around any significant narrowings and blockages in those arteries in the legs?
Yeah, I mean, I think you sum it up to no pain, no gain. Really, it's pretty. That's a very common phrase: no pain, no gain. And we have patients, if you're walking and let's say you have joint problems, you have bad osteoarthritis. Okay, if you're going to walk more, maybe you're going to be a little too much joint damage to there, and you should stop and rest. But in the vascular system, I'm not talking about so much patients with critical limb ischemia, but patients with intermittent claudication, where there's narrowings in the blood vessels that are sort of higher up, maybe in the thigh or a little bit higher up in the groin area. Those little blood vessels, although you can't really create a new blood vessel by walking, you get these little, the main highway may be blocked, but we're opening up little passage roads all around on the sides of the highway, those little side highways. So, if you use Waze or Google Maps, if there's a traffic, you find the little side streets. And the more you do, the more you walk, and walk through that pain. And that pain will eventually not start after 5 minutes. It'll start after 10 minutes. And as you continue to go around, you hit that Macy's a couple more times, you hit the Starbucks, then, 15 minutes, the pain doesn't, bother you. And then, you're walking, you can get through a mile. I had a patient, it's actually funny. Um, terrible blockage. And they say, yeah, I'm walking 3 miles. I'm like, well, you don't need a procedure. So continue to do what you're doing, and we'll talk in a year. So yeah.
That's such a good point. We have patients that come to us and they post in the group the results. Oh my gosh, I got a blockage. Oh my gosh, I'm really freaking out. I got a blockage. I don't have an appointment with the doctor for another 2 weeks. What do I do? It's like, whoa, this is really good because there is something you can do. You can walk. And would you mind explaining that the doctors don't necessarily choose the treatment plan based on what they see in the imaging? It's really the symptoms combined then with what they see in the imaging that dictates the treatment. But it's really
Oh,
those
yeah.
symptoms.
I mean, that's really the whole story. The imaging plan will give us a roadmap if we're going in, and that can help us determine what the best access point might be. Maybe depending on how advanced imaging, what sort of treatment option. That's something else we didn't really talk about earlier. I just want to circle back in terms of experience. You want to be with a physician who knows how to use pretty much every technology that's out there. And there is a lot of technology, and there's a lot of new, rapidly advancing technology. We happen to be lucky as part of our group that we're involved in quite a bit of clinical research, and we may have access to technology that's not out there. But at the very least, and especially when I'm enrolling patients, I'm always saying that this technology is at least as good as, let's say, this balloon or this stent or this device. We can't necessarily say that for sure, but most of the time when we're enrolling in these trials, we're doing what we would have done, and then sometimes this is like an extra add-on that you may not be able to have access to, and a lot of those patients are specific, symptoms and have to have very specific findings, but you really need to be at a doctor who has the capability to do all types of treatment. And if they can't do it themselves, and be able to refer. I work very closely. I happen not to do open surgery. That's not part of our specialty. So I don't do open bypasses. But I know exactly when a bypass, is going to be better than an endovascular approach, and kind of vice versa. So we have a team that we work with. It's really multidisciplinary. And I always find that most people, there's some that are phenomenal at everything, they're just gifted, but most people are going to be a little bit better at one thing than another. And you want the doc that's the best at that thing. And you could recognize and not be ashamed to say, listen, I don't think this procedure is right for you. I think another one is right for you. And if you worry about referral patterns, the best referral pattern is when you tell a patient that I'm not the right person to fix this for you because somebody else is, and they really trust you because you're being honest with them.
Yep. I I went to an ophthalmology conference and they had a class on the importance of encouraging a second opinion to your patients. And the reasoning was not very good
Hmm.
for the patients, but it made sense. They said that 75% of patients that they told to go get a second opinion never went to get the second opinion because they ended up trusting the doctor that told them to get the second opinion
Right.
more and said, no, we're just going to go with you because now we trust you. Now, in our world, we say, I don't care. You always still get a second opinion to make sure you do understand all options. You can
Yeah.
like them, you can trust them. They can come from the best of the best medical programs. They could have the biggest title, the head of some department. That doesn't mean anything when it comes to the practical skills necessary for your presentation of disease and what is right for you as an individual with that presentation of disease.
Exactly. That's right. You have to really, especially in these, and by the way, I like complicated problems and try to figure out what's best for this patient, etc. But one of my most favorite type of consults are like, what I kind of call the no-brainers. I mean, I'll tell a patient, especially we're seeing emergent patients and it's a very busy day. You want to try to answer all the questions, but sometimes you only have 5 minutes or 10 minutes to see the patient, let's say quickly in the emergency room or something like that. I always try to tell my patients in those situations, I'm going to talk to you now for 5 to 10 minutes, but I may be with you in the room for 4 to 6 hours. Who knows? Whatever needs to get done, that's what we have to get done. Um, and really, I think that's kind of also, the most, enjoying type, the best cases that we have is where it's life or limb,
Yep.
and you say, listen, it's a no-brainer. You need this procedure. Yes, you could have an amputation and maybe you'll do okay, but the no-brainer is like, you absolutely need this angiogram. Let's fix it, and we'll spend all the time we need to and have all the technology available. So the no-brainers I really like.
I have quite a few questions that I want to get to from some of the patients that had written in, knowing that you were going to be here today and couldn't be on. And then we'll get to some of them in the live studio audience. But a patient wrote in and said her femoral bypass, or FemFem, it failed. Have you had success bypassing this bypass and opening up the native vessels? Or
Yeah,
have you, you have?
absolutely. So we've had I mean, anecdotally, I've had patients that had multiple failed bypasses. I also want to look back and find out, okay, where was the bypass done? And also, when was the bypass done? So if the bypass was done 15 years ago, technology has changed drastically. And, I would definitely think that the native can much more easily be fixed. We have so many cases where you're able to go in through the native vasculature and revascularize. Sometimes the bypass did tie off some blood vessels that makes it difficult. And at the same time, we're able to then revascularize from an endovascular approach. Okay, that's a lot of words, but go through the blood vessels and go through that bypass and kind of reline it, get rid of all the clot that's there. And maybe the reason why it failed was because of something below stream. So a bypass can be open, but it can have something called that it's being threatened. It's being threatened by some inflow problem above where the bypass is, or more likely in patients who maybe have more further advanced disease, something that's distal to it or closer down to the foot beyond where the bypass touchdown point is. And those are things you need to fix also. You can't just open the bypass to maintain it being open, but you might need to fix some of the things below it. Also, medication. Some people are resistant to certain types of medication, and or
Like
simply
Plavix?
they didn't like Plavix, exactly. They simply didn't take their medication for whatever reason. That closed it down, and now we're going to make sure that they're going to stay on those
Mhm.
antiplatelet and blood thinners and that class of medicine. Or maybe now they're stopped smoking and there's a better chance. So the answer to that is absolutely. We've opened up the native femoral vessels and had excellent patency, and we've opened up the bypasses themselves and have had good patency.
Well, we always tell people when they come to us, and we see a lot of people coming to us and saying, I have a FemFem coming up. What do I need to know? And we always say, well, get another doctor's opinion, because the issue that I have with FemFems, and I don't understand how doctors don't consider this and don't have this discussion with the patients, is legs mirror each other. PAD in most patients, it's both legs. And it's only a matter of time where the leg, a femfem. So do you want to explain the femfem for bypass
Oh,
to
you mean
people, or do you want me to?
across, from one side to the other side?
Right. So the femfem, yeah, from the one side of the SFA to the other, or they even have done
Yeah.
them higher.
Yeah, so
And the
I mean, I don't perform that procedure. I've had patients who have had that, many years. I feel like that procedure itself in my area is not as commonly performed. I have one
Mhm.
patient who actually had a very interesting case. He had a AAA repair, so that was an aneurysm, which I know we talk about often. That was the ballooning of the aorta. He was fixed in another hospital for that. It was actually a very difficult procedure for them. Apparently, it was a rupture, and eventually they fixed it. But one of the problems was on the left side, that limb of the iliac, of the blood vessel that was in the pelvis, kept closing for some reason that we didn't know. I was actually able, he came to us for claudication. He could not walk at all, no matter what. He couldn't walk. He tried to exercise. It wasn't. He was a young guy. Um, And so I was able to very easily get through that blockage. And we said, you know what, rather than doing any major surgery, let's put a stent in. It closed within a month. So
Oh,
I
wow.
thought, yeah. So I thought there's something else going on anatomically that there's a problem. So I spoke, I actually had, we did it with our team together, and I was, me and myself and the surgeon, we were discussing, what the best way to go about. Should we try again to do it? So we saw there was one little area. We tried again to do it because it was so easy and it was going to avert a major surgery. But again, a couple of months later, he felt great relief. So we knew it was definitely due to the blood flow issue, but it closed. So at that point, we said, you know what? Let's do a fem from the real, that donor side. Now, in this case, the patient did not have any bad vascular disease from the leg down.
Yep.
Everything was beautiful. It was pain. It was widely open. His main issue was above the hips. And he told me, and he's an older vascular surgeon, it's like, wow, I haven't not done a fem and like, in the longest time. So it's not as commonly performed as it had been in the past.
Especially by more advanced doctors, because you realize that it's not a matter of if you have a PAD patient, it's not a matter of if it's going to go down, it's a matter of when. And it's not just one leg that's going to go down, it's going to be both, because the one leg is feeding the other. You're taking and rerouting blood flow from one leg, and assuming that one leg is going to stay the same and stay great, and you're using it to feed the other leg. And we see them going down all the time. I get so many calls from patients going, I had a fem, it went down. What do I do next? My doctor says there's no options. I can't even walk. And
Right. So
so
we've
we
had so
always,
many of those cases where we're able to just fix the native iliac. The case that I
yes,
was recounting now, that was a special case, and that's kind of why I brought it, because that was a perfect
there are always
example
exceptions.
when
Yep.
exactly. But in general, I don't think that that's a a usual case that's going to be performed in modern vascular medicine.
A patient is asking why vascular specialists don't automatically check to ensure no venous insufficiency prior to opening up the arteries in an endovascular procedure to make sure that the vein valves are healthy enough to support the restoration of blood flow. And so she says she's asking because after her arteries had blood flow restored, she ended up with a lot of swelling and a lot of pain afterwards. And the doctor told her it was because the valves got a little lazy, not having a lot of blood flow going to them for so long. So the bad veins needed to be closed. And she's like, well, why did we not figure this out sooner? I'm
Right.
curious from your perspective.
Yeah. Yeah, that's a hard question to give a good answer to. So when I have very advanced peripheral vascular patients who who had significant blockage, usually multi-level blockage. When I mean multi-level, I'm talking about, in the thigh and the knee area, and then from the knee down. So multi-level, and then we fix it, and their chief complaint, their biggest complaint is always this leg swelling. And I often tell them before the procedure, but if for whatever reason we didn't, or it didn't, compute, I'm always very happy with that, because to me, that means you're seeing blood flow, your foot, your veins are seeing blood flow that they have not seen before. And so your main problem of healing that wound is going to be very good. But yes, it does create a secondary problem of leg swelling, possibly due to some venous insufficiency. Now, the alternative is not doing the procedure, which, for limb ischemia, you definitely want a limb. I'd rather, see a patient with a healed wound and a little bit of a swollen limb that's slowly getting better than no limb at all. So,
Yep.
sometimes we can't, I want a perfect result, but we can't necessarily always have everything perfect when we're dealing with very advanced disease. There's also a disease process, which I think a lot of people overlook, which we term CAVI, which is combined arterial and venous insufficiency.
Mm-hmm.
And oftentimes, you don't even need to do testing for it, but you could just take one look at our patient's leg and say, I know this patient has combined arterial and venous insufficiency. It's clear. The question is, what to fix first. Usually, unless it's a venous ulcer, and even in that case, there's going to be an arterial ischemic component to it also. We'll almost always fix the arterial component first, because there is some belief that if you have slow blood flow going down and you compress those legs, you're compressing some of those other twigs that are feeding it, and that's not good. And I've seen a couple of times where that can worsen the appearance and the pain. So you fix the artery first, you get some worsening of that swelling, and then oftentimes you do have to take care of those veins, either the superficial veins, which is usually a very routine and easy type of procedure that we do for cosmetic purposes, or sometimes also for the deep veins. But a lot of times, leg elevation, I'll order mechanical compression pumps for our patients. You kind of have to get down to the root of the problem. You could get a venous ultrasound, but I'm not sure if it would change too much of what that physician did.
So we're getting a lot of questions about
Okay.
traveling with PAD. And so I have a few of those for you, which I think are pretty interesting. If I have peripheral artery disease, what precautions should I take when I fly?
Okay. I think that if people are taking short, flights from, I'm based in New Jersey, so I'm always thinking going to Miami, maybe going to California. Flights under 6 hours and not going across the Atlantic from here. I don't think there are too many precautions that need to be taken. I have patients who have severe venous disease. We'll always recommend wear compression stockings on the plane. And, there's one patient I've had who always, for some reason, has gotten pulmonary emboli and DVTs in the past. So they'll arrange for maybe a Lovenox, a blood thinner shot before when they land, and then maybe, the night before they go. But in general, for peripheral arterial disease specifically, I don't really recommend anything to do or to avoid. Just don't smoke on the airplane also. But that'll get you a
And
big fine.
hydrate, hydrate, hydrate,
Yeah,
hydrate.
yeah. I think all the common things. I mean, I'm not scared of flying. I get nauseous. I'm flying, so I'll take Dramamine before a flight, or something like that. But yeah, drink.
But if I'm not on blood thinners, should I talk to my doctor about doubling my aspirin dosage on the day I fly? You mentioned Lovenox, and Lovenox, if people are really concerned that they may have something that's a possible option. I know that was an option for my mom because she had a pulmonary embolism on a flight at one point. And so she did do the Lovenox before and after. But for the general public who haven't experienced it, or who don't want to experience it, would talking to your doctor about a couple of aspirin maybe help?
Yeah, I mean, I don't see, I haven't seen anything in the literature. I'm pretty up to date usually. With that, I haven't seen anything with anybody traveling in peripheral arterial disease. I think just do normal activity. If you feel like you are going to cramp up, get up, walk around the cabin, when it's safe, obviously, every, couple of hours. Um, try to sleep, watch a good movie. I don't think that medically for peripheral arterial disease, that you're putting yourself at risk. I don't believe so. Now, depending on
What
where you're
about
going, if you're going somewhere where you may have an open cut and you're going to be wearing open-toed shoes, that's where I think there could be a problem. Your destination, I've had patients who come back from Aruba, and I specifically say that because I know of one patient I'm thinking of who stepped on something. They went snorkeling. They didn't wear the good shoes on the bottom. They're diabetic, doing great. We had treated them, healed them. Everything's ready. Comes back. I'm like, how did this wound recur? Oh, stepped on a rock or on a shell, reopened the wound, and there you go. So I think what you're doing when you get there is probably look at that better than just on the flight for peripheral arterial disease patients.
you mentioned compression socks, but we hear this all the time from PAD patients and some of the PAD patients that also have venous insufficiency, and then you're going to be calling it the combination peripheral vascular disease. But should I talk to my doctor about wearing compression socks on the flights, and what level is okay for PAD patients? Because some doctors say that compression is contraindicated for people with PAD, and especially later stage PAD.
Right. So somebody that has intermittent claudication or asymptomatic peripheral arterial disease, I think you'd be very safe with 15 to 20 millimeters of mercuries. You can, calf high up to the knee. Those compression stockings, I don't think are going to cause a problem. They've really shown studies I've seen some papers recently because when I had that issue with my patient, I did a deeper dive. That was about like 15 years ago, and I'm not terribly concerned if you wear 15 to 20 millimeters of mercury, um, compression stockings for that. For patients who have severe critical limb ischemia and are flying, I'd want to know a little bit more about their overall, abilities. Are they completely not mobile? Well, why are they flying for? Are they flying for vacation? They're flying just to get back, maybe, to see some family. Like, what is the purpose and nature of this visit? Um, to give them a little bit of better advice because a lot of end stage patients of mine who are really sick, I don't think that they're taking just flights randomly. So I think the patient who's taking flights, going on vacation, and I have a lot of patients doing that. And I have some patients, they take their mechanical compression pumps with them. They go on cruises, they go to Mexico a lot. They like to, to really travel, and it's great. But some of my sicker patients, I don't really see them doing that. So I think if you're able to ask that question, you're doing pretty good. I think it would be okay with 15 to 20.
I want to get to Douglas. Douglas has a question. Douglas, go ahead and ask Dr. Herman your question. And if anyone else has questions, go ahead and raise your hand or put it in the chat that you want to ask a question. Douglas?
Yes, sir. Thank you for joining us. Great conversation. We get this a lot in the group about exercise. People can't walk, the importance. Some people talk about biking, swimming, and things like that. Is that as important as walking? We all know it's not, but can you stress about just walking to the end of the couch, just walking to the end of the driveway? That is still important, no matter if you can't walk that 30 minutes or an hour. And I have another one now. I have good blood flow in my leg, good collateral, but I cannot mow the yard. I cannot push a mower for 15 minutes without my left leg just completely going nuts on me. Can you explain that maybe a little bit?
Sure. So all activity is great. So, one of the things I would say for a question for the first part is, why is the patient not able to walk? Is it because it's too painful to actually walk? If you're just walking a little bit, you're probably not even recruiting enough blood flow that area to get that ischemia, most likely. So is it because of their body habitus type? Is it because of bad arthritis? Is it because of weakness, debilitation due to so many different reasons? So if it's just peripheral arterial disease with blood flow issues, then yeah, walk through that pain and doing a hand bike or something like that is not really necessarily going to help with the lower extremities. But if it's something else, then trying to get as much mobility as you can. There's these different types of yogas like chair yoga and different massage therapies and hand bikes and little, type kind of things like a pedal that you can push your feet with, like, up and down against some sort of a pneumatic compression. So all activity, getting the blood flow going, I think is super important. And it's really just about the mobility and being able to even to undergo some sort of physical therapy as well. Regarding your pain with the mower, is your yard very hilly? Is it flat? What's the story?
Pretty flat.
Pretty flat. Okay, because I was thinking that was very hilly that you would be increasing your demand at some point for that. So you can just go straight for 15 minutes, and all of a sudden, where's the pain in that left leg? Where does that happen?
Starts in my hip and it goes all the way down, and then it just goes numb on me like it used to before I had what I had done.
Right. So you have a known diagnosis of peripheral arterial disease, because sometimes you can have two confounding factors. And I don't want to, get too many details if you don't want to share on here. But there's also, it could sometimes also be due to, musculoskeletal issues, back issues, spinal issues, and it could be a combination of both. It could also just be a combination of kind of the way you're pushing the mower. But if a patient has experienced peripheral arterial disease type pain, then I think, whenever I ask my patients who I haven't seen in a while, for whatever reason, or if they're coming back and say, listen, that pain that we had before we started, it's exactly, back now. So then, it's due to some sort of a blockage. And you've possibly exhausted all exercise and lifestyle modification factors. And it may be time to re-intervene, and try to reopen what was there.
Thomas has a question. Thomas, go ahead and unmute and ask Dr. Kevin Herman your question.
Thanks, Kim. Thank you, Dr. Herman, for being here. And you've just put so much meat on bones of understanding that I've had. I'm a PAD patient myself, and I had angioplasty just a couple of weeks ago. Unfortunately, following the angioplasty, I developed a pseudoaneurysm, and thankfully it was a small one, so it didn't require any intervention. I had to stay in hospital a couple of extra days. But as the swelling and now thankfully some of the bruising from the angioplasty has gone, I've been left with, and I think it's reducing, but I've been left with a lump at the point where the wire entered my left groin. And I was wondering, are pseudoaneurysms like that common? And is the lump likely to diminish completely? And while I'm talking, rather than keep coming back, one concern I have in terms of the lump was, if I needed a repeat of that procedure, would the lump being there at the point of entry for the wire, would that be an impediment or create a problem if I needed to have the same procedure again? Thank you.
Right. Yeah, no, I'm glad that you're able to get the procedure. But that is a known, we could call it a complication of accessing a blood vessel, initially with a very small needle. And then as we go, we put in, I like to call it a straw. It's called a sheath, that we do all of our work through. And when you kind of close that down, when you take everything out, depending on how it's closed and also depending on how bad the calcification of the blood vessel was at the access site, how much blood thinners you were on, and even if they use something called a closure device or not. There's so many different factors in that happening. And who did the closure? A lot of times you can have, and I always say this, and I'm not in a, I'm not sure there's a good thing to say or a bad thing to say, but I'm not, I happen not to be in a teaching hospital where we have fellows accessing the procedure. But I always felt the most dangerous parts of these procedures is, and where we can have problems, is the access point and the closure. And a lot of times, I'm not criticizing at all, but those I am super anal about that, because that's really where, untoward effects of really fixing the other side can occur. I think if they didn't want to do anything with it and it's small, that pseudoaneurysm, which is basically just like a little bubble that formed at the scar site of the tissue, if you will, usually that kind of goes down on its own. The purpleness, I always tell patients, if they'll call up and my leg is purple, like, is it soft? Then you're fine. If it's very hard, come in immediately. And sometimes it could look bad. It can get purple from your groin all the way down to the knee. I've seen that. And it just travels. That's just basically, if you drop a little piece of blood, in water or something, it would just spread everywhere. You drop a little, red paint or something like that. So it's not necessarily something to be concerned about. The fact that we don't usually access the exact same point. So I think if you needed the intervention, again, you should be okay. Just if it's being performed by the same physician, just try to figure out, why did that occur? Did it occur immediately? Did you not have enough bed rest, for example? Or did the closure device fail to close because of the calcium? And there's could be, for another reason. I've had patients who developed a pseudoaneurysm a couple of days later. But in general, I've also had a patient, and I'm always afraid of them. I had a patient who had a pseudoaneurysm that was huge, and it was just there, and they came back. It wasn't actually my patient who did the initial procedure. They presented to us with this pulsating mass in their groin, and and it didn't rupture. So the the normal progression of these is that they do generally close, but sometimes we have to inject like a little bit of a glue type of substance in to close it down. So I would definitely, if it was last week, I would definitely get a follow-up ultrasound if I were you in that area, just to make sure it's going the right way.
Thank you very much. Thank
You're
you.
welcome.
Thank you, Thomas. Alan, go ahead and ask Dr. Kevin Herman your question.
Yeah, I've got two questions, and Kim, maybe you would be better with the first one. I'm not certain. First question is, I've transitioned from smoking cigarettes to using a nicotine substitute product like Nicorette. And Kim, you made the comment that nicotine makes your blood sticky. Does that mean that the substitute product I'm using is doing the same thing as actually smoking a cigarette?
So you're not smoking, you're actually using like a patch or gum.
Yeah.
Dr. Herman?
Yeah, so I think it's not just the nicotine, but all the other stuff that's in the cigarettes that's going to make it worse. I also
Okay.
don't know about the level. I don't want to call myself an expert, about nicotine level and the exact pathophysiology, but in general, it's probably the dosage of the nicotine is probably going to be less overall than what you would be inhaling when you're taking a cigarette, and also just the mechanism of action. My guess would be that it's better.
Okay. Thank you. Second question.
I'm glad that you didn't ask about vaping, because that was, initially vaping we were talking about, but then vaping comes with its own problems of all these
Yes.
different lung diseases. So,
Yeah.
I'm not going to say one is necessarily better than the other, but a glass of wine is not necessarily bad.
Okay.
It's interesting because world-renowned PAD research analyst Mary Yost at a recent New Cardiovascular Horizons conference in New Orleans. She gave a presentation talking about how we're seeing presentations of PAD. It's no longer an old person's disease. It's now a younger person's disease as well, because we're seeing more and more because of, she says, potentially diabetics as kids. So more type 2 diabetics, late in the teens, kids getting diabetes. And they're presenting actually because doctors brush them off going, oh no, your leg cramps can't be PAD. That's just
Right.
muscle cramps. Go eat a banana is what one of my patients, was told. But they were in critical ischemia because they had a wound that won't heal, but go eat a banana. But secondarily, back to your point, the vaping. And she was making the point that it's been made, these kids were made to believe that vaping was actually safer than smoking cigarettes. And I don't know. And even more than that is not just vaping of the nicotine, it's also with the pot. And the theory that I've heard is anything you burn and you're bringing into your lungs, it's toxic. And
Can't be good.
it goes straight into your blood vessels. And when it goes straight into your blood vessels, it's causing inflammation. It's damaging, and inflammation damages your arteries. And when you're damaging your arteries, it's going to trigger that inflammatory response, right? And so you're going to end up with plaque.
Right.
Okay. Thank you. My second question was, so I was diagnosed with PAD about 4 months ago, and I was walking a lot to improve my condition, and I was improving my condition. I could feel it. I could walk further, and I could walk with less pain. I've spent the last 3 days in bed because now I have anemia, and I'm not going to be, the last time I came down with anemia, it took me somewhere between 2 and 3 months to recover from it. And I know that for the next few weeks, at least, I'm not going to be walking very much at all because I have no energy. Does that set me back, or does it just sort of delay my progress?
Yeah.
If I'm not able to walk very much.
Right. So, when you say you were just recently diagnosed with PAD, if you could share with us, what would the find? You were having some pain walking, and then the doctor did an ultrasound, they did a pulse check. What did they do to find out what you have?
I had what's it called? Not an ultrasound. They
Maybe
put a
pressure
fluid.
cuffs and stuff? They put the pressure cuffs around your legs?
No, no.
Did a CAT scan, maybe a
They did,
CTA?
sorry, yes,
Right?
they did a CAT scan with tracing.
Right. Okay, fine. So, and they said they saw a big blockage, a small, or just a blockage in the femoral artery, do you know, or?
All he told me was that my worst blockage was below my left knee.
Okay. So if the worst blockage was below your left knee, a lot of times those types of blockages, and I don't know exactly where it is, those shouldn't necessarily be the claudication type. But that being said, most patients that develop symptoms like you were having, it's usually going to be multi-level. It's not just one problem. It's usually going to be at least two problems and sometimes in tandem before. So I would guess that if you're really not going to have the energy and not the ability to walk and to exercise, and I think stretching, I got into stretching recently. I think stretching is super important in general. I'm not going to say it's going to recruit blood vessels, but it's just good for your mobility and for your joints to be able to walk and not to feel so stiff.
Yeah.
You might have a little bit of a setback, but I would think also that you knew where you were, like right before, you knew how much you were walking. And I think it's gonna be much easier to get back to that level because you've already, so maybe the first day out, once you're feeling better, you may not get as far, but I think that the progress that you made will, probably, be much quicker.
And Alan, we can sign you up for our text-based walking program. We're soon going to have an app as well. It's free to patients, free to doctors. Doctors and patients have their own dashboard to be able to monitor the progress. But I think what you'll find if you use it is, I think that when you do take a few days off, you're not going to notice much difference in your claudication time. And that's really the time that you really want to focus on, because it's the time that you're pushing through, time between the onset of the pain and the time at which that pain forces you to stop. And I don't think that that's going to change very much just in a few days of you being off. And I think it'll be comforting for you to have this tracker to be able to just track that in particular. I think it'll keep motivating you to say, you know what, I had a couple days off here, but I'm still motivated because I'm not going to regress.
Yeah.
I would like to have a conversation with you further, possibly tomorrow. We do have a nurse practitioner who's coming on that I think can talk to you a little bit more about the anemia and can do a little bit more of a deep dive. So if you want to go ahead and message me, let's take that offline and we can get you on with her and ask her some specific questions on the prevention of anemia and, additional blood work, other testing that you might need done, and then as well as some treatment options that can get you back on your feet a lot quicker. We deal with this a lot. I don't know, Dr. Herman, it's like, which came first, the chicken or the egg? Because I find most of my patients are all anemic.
Really?
Yeah, they have something called anemia of chronic disease, kind of. There's not necessarily a specific reason. It's not somebody that it's bleeding that needs a blood transfusion. It's just the blood producing cells they have some sort of a disease that also is affecting the rest of the body as well. So patients with anemia can also have some problems.
We have two more questions. Do you have a second for two more questions?
Yeah,
one
sure.
From Douglas.
Yeah,
okay.
Absolutely.
Douglas, go ahead.
Yes, sir. We've been talking to doctors a lot, and I was wondering for you personally, from when you started to where you are today, what gets you excited about the field that you're in, and how did you get into this field? And was there a specific case that said, oh, this is where I need to be, or this is where I want to be? And what gets you excited today about where we're going with the technology?
Yeah, that's a great question. I actually often think about that. So I'm an interventional radiologist. I had exposure to radiology. I had some family members who were radiologists in the past. And as I was going through medical school specifically, I was trying to think, okay, what do I like? Do I like sitting in a room and seeing patients and diagnosing things and doing things like that? Or do I like procedures more? And I like the combination of both, but I was definitely very attracted to technology and procedures. And marrying those two things together, I really kind of went into interventional radiology. I recall going back to my medical school days when I was in surgical rotation. For whatever reason, they did a lot of vascular surgery in the location that I was on for that month and a half, and specifically in that location, it was at a VA And I just got it, I just sort of like I intuited blood vessels, and it's just one of those things. Like, it made sense. You have a blockage, you open it. You need to, something's bleeding out, you close it. It's just, you don't have to think too deeply into do it, but you have to be able to use a lot of ingenuity to try to figure out how we're going to fix it, how we're going to keep it open, and all these different technologies. So, and just when during my fellowship also, which is somewhat rare nowadays for interventional radiology, I did have exposure to endovascular disease. I was at Montefiore, and they had a very big and well-known vascular surgery program, and everybody really played nicely in the sand. And it was wonderful. We went to all conferences together. We had access to be able to do the procedures. And then one other thing I think is also timing. I'm in practice for 15 years, and I think, when I talk to my partner who's been doing this for quite a bit longer, and you look back at the history, it seems to me that about 15 years ago, there's been sort of a technological shift, if you will, a little bit of a technology shift where a lot of the products that we're using and the tools that we're using are coming smaller and smaller. So, so you're able to go into those smaller blood vessels. And as the technology really advanced, so we were happy to try them and to use them, and, using our skills, using from the old things to the new things, and then kind of marrying those together. And what keeps me excited is just, the ability to just cross through a blockage, and having that experience. I'm still doing things a lot of the same way, but always these new little tricks to get through our blockages. And the fact that, all the physicians in the field are so dedicated, to it, and they're coming up with new ideas and new procedures and new ways of doing things, and new medicines also to try to keep these devices open. So it's really a combination of technology, patient care, using your hands, and some of it I just, kind of, I intuit it more than other things that I do.
And we have one final question that is off of pad, but it is with a pad patient. This is a newer procedure. And at American Endovascular, you perform hemorrhoid artery embolization. And a patient has asked us a question about the excessive bleeding due to hemorrhoids, and her interventional radiologist offered hemorrhoid artery embolization. And so she wants to know if you can talk about this procedure, the process, its benefits, potential complications, any questions she should be asking her doctor before determining if it's even right for her.
Right. So I'll talk more, at a gloss over of it. It's a new procedure. Has a cute name, embroid, so it's like an embolization of the hemorrhoids. The embolization is an old technology. And am I able to hear me well? Embolization is an old technology. Patients that have GI bleeds, right? So they're, for some reason, the bowels are bleeding internally, or patients, in fact, there's one amazing procedure called a uterine artery embolization, which what we do for that is we're able to shrink fibroids in women suffering from fibroids, anywhere from, I don't know, 25 to 55, or even above and beyond. They're suffering from fibroids due to heavy bleeding. They found in a patient who emergently they needed to stop the bleeding that the fibroid shrunk. And so we'd use, sometimes in certain procedures, we use these little particles to close down the blood vessels. And other procedures, specifically the embroid, we use something called the coils. They're like little staples that stop the blood flow. So hemorrhoids are obviously, they affect millions of patients. And kind of, do you need a treatment or do you not need a treatment? Most of the time, it's not necessarily life-saving, but it could be life-changing. And there are different scales for how bad people's patients' hemorrhoids are, and how much bleeding. Is it always bleeding? Is it just bleeding after, going to the bathroom? Or is it painful? Is it a combination of both those things? So I think the determination of whether or not a procedure should be performed, I think it's good to talk to physicians who've been doing this for a very long time, not just to say I have a hemorrhoid and let's fix it. There are some non-invasive procedures like banding, where they put some bands around the hemorrhoids. There's also surgical procedures, and also where they can inject the hemorrhoids with a sclerosing agent to close it. The problem with these is that some of them you need a cut, you make actually an incision, and they can be quite painful, and the recovery can be quite painful. There was another procedure performed by a surgeon through like a scope that goes through the anus, where they looked at the blood vessels. So it can be that there's some what they call the corpus cavernosum of the rectum area can dilate up, and it's really potentially a blood vessel problem. Not peripheral arterial disease that there's a blockage, but that they're kind of got too big. And they were going from the rectum through, using some medicine to get into the blood vessel to close those down. So that got a group of enterprising interventional radiologists to think, well, why don't we go through the blood vessels and the other way? And it happens to be that the blood supply that goes there is quite easy to get into. And we've been in there as interventional radiologists, oftentimes in the middle of the night when we have something called a lower GI bleed. They have bleeding, patients are bleeding from the rectum. We're easily able to get into what's called the inferior mesenteric artery, which is the blood vessel that feeds the lower portion, and specifically going towards the rectal arteries. And we have the tools, we have the technology to get into those areas, and using these small little catheters and wires is very, very safe. And we do it for life-saving procedures for GI bleeds specifically. And in this case, we can start doing them for coil embolization. So I've done many, many coil embolizations at that location. I have not treated very many patients yet in our practice for hemorrhoids. But we've done quite a number of prostate artery embolization, genicular artery embolization for knee pain. That's a fantastic procedure that seems to be really helping avoid knee replacement, or to
That's
slow
a
down
good
the
one.
knee.
Yeah, we just had someone who came to us and said that she's up for a knee replacement. And I said, well, you have PAD. Are you sure you want to go straight to the knee replacement? Or would it be helpful just to try a minimally invasive procedure like the genicular?
Right. Yeah, my most common patient now is somebody that had a knee replacement on one side and said they don't want to do that again for some reason. Let's try this first. That's like the most common patient. Listen, there's something to say about definitive surgery for the knee replacement in the right patient, absolutely. But we're here to try to help out as much as we can. So whether or not you need it, you have to. I would talk to those doctors, but it's very safe. It's very effective. We don't have great randomized controlled data. I don't think we have actually any. There's some data on that other procedure that I talked about. That was like kind of the reverse. It's the same idea, but actually going using a scope through the anal region. But that it should be very easy to do. Like it should be, you should be in the order of 95% successful in doing the procedure. And I think the numbers could be, in the 85% range, probably for initial success. And then obviously over time, new blood vessels may form, and therefore those rates would potentially go down. And complication should be quite minimal in that area. You're not going to have bleeding in that area because you're closing down the bleeding. But and you're not closing down enough blood supply to cause ischemia, so that should not be a problem if done properly. And really just the access site at the groin, and you just got to be careful with that.
And I promise we just had just final one come in from YouTube.
Sure.
One, we have Nighthawk who wanted to thank you for coming on, Dr. Herman, extremely informative. And so he says, thank you. Another one came in from Ahmed, diagnosed with Berger's disease. Now Berger's is really the smoking and
Yeah.
I'll let you explain it. But diagnosed with Berger's 1 year ago, have an inclusion though in the posterior tibial artery. Is treatment for that the same as for PAD? Would an intervention be beneficial?
So hard to
I'm
answer
That's a
over.
tough
Yeah, I
one.
mean, Buerger's disease is a small vessel disease. They call them like this corkscrew vessel appearance. First of all, are you having symptoms? That would be my first question. Are you having symptoms in that area that would warrant treatment? People usually have 3 blood vessels that go down to the foot, unless there's a wound specifically being fed by one blood vessel. And that's time for another talk. about, when to intervene, even though you may have adequate blood flow, it seems. But I would, need to know about symptoms. The answer is theoretically yes. Most things are fixable, but I don't think that in this case it might, that might not help, or
Yeah,
or may not be needed. Hard to
we've
know.
dealt with a lot of these patients with burgers actually over in the Philippines and in a couple of other countries as well, India and one in Pakistan. And what we have found is that the symptoms seem to dissipate when the smoking stops. And within a few
Right.
months, it seems like things typically, and correct me if I'm wrong, they seem to resolve themselves. We were able to prevent all 3 amputations because of just literally the act of not smoking and then
Yeah, we
proper
have a
wound care for
right, we have a
wounds.
patient with that who stopped smoking, but still the wound would not heal. And we actually, I think we did a DVA on that patient and got them out of
Interesting.
trouble. Yeah,
And that was with burgers.
I believe so. Yeah,
Oh,
it was a
interesting.
little while back, but I believe so.
So there are options available. So it's really good to have that discussion with the doctor, especially if you are having symptoms that are not improving over time, even when you quit smoking. So
Yeah.
thank you so much, Dr. Herman. You have been more than generous with your time. We really appreciate you. We hope that you'll come on again at some point in the future. And we thank you so much from the bottom of our heart for being here. And I am going to stop the stream, and if anyone has any further questions, go ahead and post them in comments, and I can get them to Dr. Herman for a later date. And we also have doctors coming on every single week right here on our YouTube channel. So make sure to like, make sure to subscribe, make sure to follow us so that you can get notified when we have doctors on every single Tuesday for our What's Up Doc series. And also, make sure you tune in tomorrow. We have our nurse practitioner, Deidre Arms. She's going to be talking about potassium deficiencies. So if you have questions about that, make sure to tune in there. And on a week from Wednesday, she is going to be talking about iron deficiencies. So, Alan, you might want to be tuning in for that one as well. Have a
Yeah.
great week, everyone. Make sure to go to padhelp.org. If you have any concerns about your legs, call the Leg Saver hotline at 415 320